And the main focus of the class will be today the optic pathway and a special mention about the lesions of the optic tract, right? So our main focus is going to be the lesions of the optic tract. We'll try to make it a bit simple as possible, right? So suppose I put up a question to you, right? Let us begin with a question that is going to be a brainstorming to us. So just let us go with a brainstorming, right? Now tell me, a 49-year-old woman is coming with to the ophthalmologist. She complains of a slowly progressive loss of vision, and based on the visual defects which are shown to us, the ophthalmologist determines the patient as a right-sided homonymous hemianopia, right? A right-sided homonymous hemianopia, and she's being referred to a neurologist who then suggests a CT scan. When there is a CT scan, obviously there is going to be a high density space occupying lesion which is compressing the brain. Now just looking at the lesion, tell me that where is the site of lesion? A, left optic nerve, B, left optic tract, C, its optic chiasma, D, the lateral geniculate body, or E, the right visual cortex. So look at the diagram very nicely, which is reflecting you a hemianopia, which is said to be a right-sided hemianopia. So what comes into your mind when you come with a right-sided hemianopia, right? So the correct answer is B, right? The correct answer is B. That is, there is a loss of vision on the right half of the visual sides of both eyes. You can see over here that the right side of both sides are there, and this is because of the involvement of the optic tract. It is because of the involvement of the left optic tract, right? Now let us consider it further. So before we go or before we move on, first it's very important for us to clear the optic pathway or the visual pathway. Now you know that the visual pathway, where does it begin from? The visual pathway begins from the axons of the ganglion cells, right? The visual pathway, it begins from the axons of the ganglion cells, which are going to form the optic nerve. Now over here I would just like to enlighten you one thing, that there are different cells in the retina. You know that there are bipolar cells, horizontal cells, amacrine cells. Among all these cells, the cell which is basically reflecting or showing the true action potential is only the ganglion cell. It is only the ganglion cell. The cell which shows true action potential is only the ganglion cell. Rest all other cells, they show graded potentials. Like that, all other cells, they show graded potentials, right? Now when the axons leave the eye and they form the optic nerve, they leave the eye from the optic disc, which is supposed to be the physiological blind spot, right? They leave the eye from the optic disc, which is the physiological blind spot. Now as they leave the eye, this optic nerve, what will this optic nerve have? This optic nerve will have nasal fibers and temporal fibers of the same side. Nasal fibers and temporal fibers of the same side. Temporal fibers and nasal fibers of the same side, right? So if it is a left optic nerve, it is going to have left nasal and left temporal. If it is a right optic nerve, it is going to have right temporal and right nasal. Now these fibers, they are going to come at the level of optic chiasma, right? They're going to come at the level of optic chiasma, where there is going to be decussation or there is going to be crossing. Who crosses? Only the nasal fibers cross, right? There is crossing only of the nasal fibers. There is crossing only of the nasal fibers, and this is eventually going to form the optic tract. This optic tract will have now uncrossed temporal fibers, uncrossed temporal fibers, and crossed nasal fibers, crossed nasal fibers. right? This optic tract will have uncrossed temporal fibers, that is the temporal fibers of the same side, and crossed nasal fibers. That means if it is a left optic tract, right, if it is a left optic tract, it is going to have left temporal fibers. If it is a left optic tract, it is going to have a left temporal fibers and right nasal fibers, right? It is going to have left temporal fibers and right nasal fibers. Now this optic tract is then going to come here in the lateral geniculate body. This lateral geniculate body plays a very, very important role. It acts as a relay center, right? It acts as a relay center. It also helps in the depth of perception, in perceiving the depth of perception. So relay center, depth of perception, and it plays a very important role as gate. That means it controls the amount of impulses that should reach to the cortex. So the lateral geniculate body acts as a relay center, helps in the depth perception, and acts as a gate controlling the impulses reaching the visual cortex. Now you can see that these are in the form of radiations, and therefore this is called as the optic radiations, or also called as the geniculocalacrine tract. Geniculocalacrine tract, which is reaching all the way to the visual cortex, into the primary visual cortex area 17, 18 and 19, which are the visual association areas, right? Area 17, which is the primary visual area, and area 18 and 19, which are supposed to be the visual association areas. So remember that optic nerve reaching the optic chiasma, crossing of the nasal fibers, forming the optic tract, relaying in the lateral geniculate body, and then finally terminating into the visual cortex in the form of optic radiations. Now if you see that this is again very, very important. There are 6 layers, okay, there are 6 layers in the lateral geniculate body. There are 6 layers in the lateral geniculate body, and the contralateral, okay, the contralateral nasal fibers, the contralateral nasal fibers, they terminate on the lamina 1, 4 and 6 of the lateral geniculate body. Can you see layer 1, 4, 6 of the lateral geniculate body? So these are the crossed fibers which are entering or which are terminating in the lamina 1, 4, 6 of the lateral geniculate body, whereas the uncrossed fibers, right, whereas the uncrossed fibers, that is the temporal fibers, they are coming into the lamina 2, 3, 5 of the lateral geniculate body, into the lamina 2, 3, 5 of the lateral geniculate body. So lateral geniculate body plays a very, very important role. It is supposed to be the relay center. It has got 6 layers, and the terminations of the crossed and the uncrossed are different in the different lamina, which you can also see over here. Now it has got 2 pathways, the magnocellular pathway and the parvocellular pathway, right? There are 2 pathways, which is the magnocellular pathway and the parvocellular pathway. This magnocellular pathway has got bigger cells, magna cells, or a bigger ganglion cells, whereas the parvocellular pathway has got small to medium sized P type of ganglion cells. So here there are M type of ganglion cells, and these are the P type of ganglion cells. And what is the peculiarity, or what does the magnocellular pathway and the parvocellular pathway they carry? So if you want to remember, this is the magnocellular pathway consisting of the M type of cells, because it is magno means bigger, or the Y type of ganglion cells which enter into the layer 4 of the striate cortex. This pathway, magnocellular pathway, is mainly concerned with movements, depth, flickering information, and very, very important, it is responsible for the black and white contrast. It is responsible for the black and white contrast. So this is a black and white pathway. The magnocellular pathway is basically a black and white pathway. Whereas this parvocellular pathway entering into the layer 4 where there are present of blobs, and blobs is important because this is concerned with color vision. So in a nutshell, what we have to remember is that the parvocellular pathway is responsible for the color vision, whereas the magnocellular pathway is responsible for the black and white contrast. Right? Now let's move on forward to the topic of the today, that is the lesions of the visual fields, like the lesions in the visual field or the visual field defects. Now when you consider this visual field defect, certain important things which you should know. You must know always that the nasal fibers are going to form the temporal vision. Right? The nasal fibers are going to form the temporal vision, whereas the temporal fibers are going to form the nasal side of the vision. This is something which is to be importantly known to us. Right? This is something which is to be important to known to us, that the nasal fibers are going to form the temporal vision and the temporal fibers are going to form the nasal vision. So once we are clear with this, there is less confusion and a clear understanding. Right? And when total loss is there, it is anopia, whereas half side is lost, it is supposed to be hemianopia. Now let's come on to the first defect, where the defect is in the optic nerve. Right? When the defect is in the optic nerve. Suppose this is the right eye, this is the left eye. These are the nasal fields and these are the temporal fields. Now for our convenience, just let right, left, so that we understand the homonymous and the heteronymous in an easy way. Now when there is a lesion of the optic nerve, for example, which is shown over here, is the lesion 1, where there is lesion in the left optic nerve. Now this optic nerve has got fibers, that is temporal fibers, nasal fibers of the left eye itself. There is no crossing yet. Right? There is no crossing yet. So it is having temporal fibers, nasal fibers of the same eye. Right? Temporal fibers, nasal fibers of the same eye. Therefore, with lesions of the optic nerve, there is going to be a total anopia. A total anopia. Suppose if it is a left eye, total anopia, that means loss of vision of the nasal side and of the temporal side of the same eye whose optic nerve is being involved. For example, in optic neuritis. So when the optic nerve is involved, there is lesion of the same, there is a loss of vision of the same eye, a total loss of vision of the same eye, anopia. Right? Now second, let us look into the optic chiasma. Right? Second, let us look into the optic chiasma. There could be either involvement of the lateral portions of the optic chiasma or the central portions of the optic chiasma. This is common when there is a pituitary lesion or a pituitary adenoma. So a pituitary adenoma is going to compress these nasal fibers. Right? The pituitary adenoma is going to compress this nasal fibers. So suppose this is the right eye, this is the left eye, and the nasal vision and the temporal vision. And let's, for our convenience, for our better understanding, what we'll do, we'll write it right, left, right, left. Now when it is nasal fibers being affected, so when the nasal fibers are being affected, what field of vision will be lost? Will be temporal. Right? What field of vision will be lost? Will be temporal. That means on either side there is going to be a bitemporal hemianopia. There is going to be a bitemporal hemianopia. Right? So as I told you that when the nasal fibers are affected, the field of vision that is lost is temporal. So on either eye, what is lost is temporal vision is lost. See, temporal defect in the temporal field of vision. But on the right side is involved. On the left side is involved. That means though it is a bitemporal hemianopia, the sides are different. Right side on one eye, left side on another eye. This becomes a heteronymous hemianopia. So what did I try to make you understand is that the field of the defects in the field of vision are same. That means on either side there is temporal field of vision that is lost. But the sides of the eyes involved are different. On right side, the right side of the eye is involved. On left side, the left is involved. So because the sides involved are different, though the field of vision that is lost is common, that is bitemporal, it is supposed to be heteronymous hemianopia. Similarly, when the peripheral fibers, or when there is a lateral compression, usually compression caused by the ventricles over here, that is going to compress the temporal fibers. So when the temporal fibers are lost, right, or when the temporal fibers show a lesion, there is going to be what? When the temporal fibers show a lesion, there is going to be what? There is going to be binasal hemianopia. Again, if it is a binasal hemianopia, the field of defect is same, right? The defect in the field of vision is same, that is nasal, but the sides would be different, and this would also become a heteronymous hemianopia. It will become a heteronymous hemianopia, right? So by and large, that whenever there is a lesion of the optic chiasma, there is either going to be a bitemporal hemianopia or a binasal hemianopia, depending upon whether the nasal fibers are involved or the temporal fibers are involved. But this type of hemianopia is always heteronymous. It is heteronymous. Now suppose if the optic tract is involved, right? The optic tract is involved. So let us consider optic tract being involved. Now you know that this optic tract, right? So this optic tract is going to have what? The optic tract is going to have temporal fibers which will be of the same side, that is uncrossed, and there are going to be the nasal fibers which are going to be the crossed. Suppose this is right eye, this is left eye, these are the nasal sides, these are the temporal sides, and to make our life bit easier, we are going to write right, left, right, left. Now if I consider that there is involvement of the right optic tract, right? Now if I consider there is involvement of the right optic tract, so on the right side the temporal fibers are lost. On the right side the temporal fibers are lost, therefore the defect in the field of vision will be nasal. So on right side the nasal field of vision is at defect. Now this has got crossed nasal fibers. That means on left side there is going to be involvement of the temporal field of vision. There is going to be involvement of the temporal field of vision. So that means what? The defects in the field of vision are now different. It is nasal on one side, it is temporal on one side, because here the fibers which were involved were the uncrossed temporal fibers, and here the fibers which were involved were the crossed nasal fibers. And we have learned that if nasal fibers are lost, temporal vision is affected. If the temporal fibers are lost, nasal field is being affected, right? Now you can see that the defect in the field of vision is different, nasal, temporal. लेकिन दोनों sides कौन से हैं? Left. Both of the sides are left. So this becomes a homonymous hemianopia. and because both of the left sides are involved, it is going to be left homonymous hemianopia. Left homonymous hemianopia. The tract that is going to be involved will be the right optic tract. So right optic tract is going to result in the left homonymous hemianopia, and the left optic tract is going to result in the right homonymous hemianopia. Please remember that when you are doing these lesions, never try to mug them up. If you mug them up, if you try to rectify, 100% you're going to make it wrong. Always draw and learn. Always draw and learn. This is the only way how which you can learn the defects in the field of vision, is to just learn them by drawing. Finally, coming to the optic radiations. You know, when there is involvement of the optic radiations, you are also going to get hemianopias. Homonymous hemianopias. But can you see this? This is called as the macular sparing. This is called as the macular sparing. Why the macula is spared? The macula is spared because of the large area of representation of the macula in the visual cortex. Because the macula has got a large area of representation, there is always going to be macular sparing. Right? So remember that the nasal fibers, they form the temporal field of vision, and these, what are these? These diagrams are reflecting you the defects in the field of vision. The lesion is inside the eye, and these are depicting the defects which are occurring in the field of vision, right? The defects which are occurring in the field of vision. Now you might have also heard something like this, like you get a quadrantenopia, right? You get a quadrantenopia. So this is supposed to be an inferior quadrantenopic hemianopia or inferior quadrantic hemianopia, where the commonly it is called as the pie on the floor. It is called as the pie on the floor. When it is a inferior quadrantic being involved, the lesion is the parietal lobe which contains the superior fibers of optic radiation. Superior fibers of optic radiation. This is basically depending upon the arrangement of the fibers, right? This basically depends upon the arrangement of the fibers in the visual cortex. Now, when you get a superior quadrantenopia, which is called as the pie on the sky, here the fibers which will be involved will be the inferior fibers of the optic radiation. Inferior fibers of optic radiation. Right? Now let me tell you that in the NEET PG examination there was a question which was given on the defects in the field of vision. So this topic is a very important MCQ to be considered, and not only as an MCQ, it is very important even for the first MBBS professionals. You get this as an LAQ. You also get this question in your viva. So the defects in the field of vision are very important. The visual pathway is also very important, right? So please go through this once again, and definitely you will be in the better state of understanding. So just giving you an idea about our plus subscriptions. Iconic, with a combination of an academy with pre-planner. Our NEET PG Combat, a scholarship examination every month where each and every subject is going to be dealt in detail, right? We've come up with a very wonderful option of a raise of a hand, making our classes more interactive. We are coming up with our NEET PG as well as the INICT batches, our FMG batches. So please boost up your medical pre-PG levels. We've got limited time offers. The prices are going to strike. So boys and girls, I always say that always take time to rejoice, because when you rejoice, you are refreshed enough to restart and to refocus, right? And when you refocus, you are always going to be back towards your goal. So this is all for now. A happy learning, everyone. Thank you and take care.